بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are still discussing the imaging of the middle skull base, and we have started in the previous lecture to discuss some of the lesions after presenting some anatomic details. Now we'll continue these lesions, and you remember that we have finished the issue of invasive pituitary adenoma, paracellular meningioma, paracellular neuroma, chordoma, rhabdomyosarcoma, and we are now about to discuss the last one of this group, which is the adenoid cystic carcinoma. This is an uncommon malignant tumor. It represents about 1% of all head and neck malignancies and about 20% of the salivary gland tumors. This tumor is characterized by many features. The most important of them are: number one, it has a prolonged clinical course that may be mistaken for a benign lesion in some patients. And the second one is its tendency or great tendency to spread along the neurovascular bundles. This tumor also can invade the lymphatics. It has a frequent local recurrence and delayed distant metastasis. The two important features are the long clinical course and the perineural tumor spread. These lesions are usually presenting with non-specific imaging criteria. You will see a mass of soft tissue density, of course. You can see variable patterns of contrast enhancement, but tumor calcification is rare, and the affinity to spread along the nerve bundles may lead to widening of the skull base foramina, especially the foramen ovale and the foramen rotundum. An MRI, and you have a relatively homogeneous intermediate signal intensity on T1 and T2 weighted image with moderate enhancement. Then this is an example of an adenoid cystic carcinoma of the right parotid gland. And you see the enhancing pattern of the tumor, and the tumor is spreading along the trigeminal nerve, one of the branches of the trigeminal nerve, which is passing through the foramen ovale and leading to significant widening of the foramen itself, reaching the paracellular area. And many times, whenever you are looking to this lesion, and you can see an expanding lesion with little bone destruction and rarefaction, you may feel that this is a benign lesion. But one of the very good diagnostic possibilities for such lesion is this adenoid cystic carcinoma. And if the tumor is presenting late, you may see aggressive bone destruction and so on. But this is one of the presentations of adenoid cystic carcinoma. It is an expanding lesion with some bone erosion, as you can see here in the left side of the palate, and also the erosion of the maxillary antrum. Another example of adenoid cystic carcinoma with some expansion of the maxillary sinus. This is not, of course, a mucocele. Since the mucocele, if you inject it with contrast, it will show marginal enhancement. But in this particular example, you see heterogeneous enhancement and some bone fragments within the tumor itself. then this is a more or less aggressive lesion that has invaded the nasal cavity, and it was proved to be an adenoid cystic carcinoma. Another example of adenoid cystic carcinoma in the infratemporal fossa, you see a homogeneously enhanced mass, and this mass has grown along the left cavernous sinus and reached also the orbital cavity on the left side. Then we finished the cella and the paracellular areas, and we came to one of the components of the middle skull base, which is the sphenoid sinus. And similar to any of the previously discussed sinuses, it may be involved by mucoceles, fungal sinusitis, carcinoma, and metastatic tumors. And you know that the mucocele of the sinus will lead to significant expansion of the sinus with more or less thinning rather than destruction of the sinus wall. The mucocele usually in MRI will show some increased signal in the T1 and T2 weighted images because of the mucinous component or the high proteinaceous content of the mucocele itself. And the bony expansion is better appreciated on the CT scans. And you can see the expansion, the erosion of the dorsum celli and some of the part of the anterior aspect of the clivus. And the tumor is, the mucocele is also bulging into the nasopharynx. And this is an example of the mucocele on the T1 weighted MRI images. You see the sinus is expanded with high signal of its contents. Also, analogous to the antroquanal polyp, and you can see a sphenoquanal polyp, where the sphenoid sinus is expanded by soft tissue density, and this soft tissue density is extending through the sinus draining ostium into the nasopharynx, and this is known as the sphenoquanal polyp. There is significant expansion of the sinus and some erosions of its bony margins. Fungal sinusitis can also involve the sphenoid sinus, similar to the frontal, ethmoidal, and maxillary antra that has been previously discussed with the anterior skull base. And here you can see the criteria of fungal sinusitis, including the hyperdense intrasinus material, and it will show some enhancement. You've got some calcification within the fungal mass, and also you got some bone erosions in the affected sinuses. And this is an example of a carcinoma of the maxillary sinus. It is almost similar to any of the paranasal sinuses carcinomas, where you see a mass, and this mass is enhancing in the post-contrast images, coronal and sagittal. It is seen filling the sphenoid sinus, and the sinus wall are destroyed with bulge of the tumor in the right paracellular area as well as towards the nasopharynx. Another example of a sphenoid sinus carcinoma, you remember that carcinoma is the most common malignant tumor of the paranasal sinuses and also the nasopharynx, as we have discussed before. And this is an example of a mass that is heterogeneously enhanced, centered to the sphenoid sinus, as seen in the sagittal image, with erosion of the sinus wall, bulge into the nasopharynx, and extension into the left paracellular area, most likely infiltrating the cavernous sinus. And this is also an example of a sphenoid sinus carcinoma. You can know the malignant nature of the lesion by the presence of associated bone destructive changes. And in this domain, you cannot actually differentiate between lymphoma and sinus carcinoma and also metastatic deposits. But taking into consideration that carcinoma is the most common, and you have to diagnose this destructive lesion as carcinoma. But if you know that this patient is a patient with a primary malignant tumor, then you may say that this is metastatic deposit. If the patient is known to have lymphoma, then you may think that this is also a sinus lymphoma. And here, this is a sinus carcinoma, and the squamous cell is, of course, the most common carcinoma in the paranasal sinuses and also in the nasopharynx. And you see a mass involving the right side of the sphenoid sinus, and then the mass showed significant contrast enhancement with extension into the posterior ethmoids as well as extension into the orbital apex, indicating the malignant nature of the lesion. And if you know that the patient has a primary malignancy, like this patient with breast cancer, and you see a mass involving the sphenoid sinus with some bone sclerosis of the clivus, you know that this is a metastatic deposit. And here you see the tumor of the previous case. It shows low signal in the T1, intermediate signal in the T2, and this is post-contrast, heterogeneous post-contrast enhancement. This is T1 and this is T1 sagittal image. Then we came to the nasopharynx. And in the nasopharynx, we have the nasopharyngeal angiofibroma, nasopharyngeal carcinoma, and the nasopharyngeal lymphoma, as well as metastatic deposits. You remember that nasopharyngeal angiofibroma is a benign lesion that is usually almost confined to boys. It arises near the site of the sphenopalatine foramen, and you know that this sphenopalatine foramen connects the pterygopalatine fossa to the nasal fossa. Then one of the, let us say, regular extensions of this tumor is to go to the pterygopalatine fossa. And also the well-known another extension is into the sphenoid sinus. Then this tumor is hypervascular. It presents usually by epistaxis, and it is supplied by branches from the internal maxillary artery, which are the ascending pharyngeal and the ascending palatine. Whenever you examine the patient with nasopharyngeal angiofibroma, you see a mass uh, almost central to the region of the sphenopalatine foramen, partly in the nose, partly in the nasopharynx. And frequently you see that this mass has extended into the pterygopalatine fossa as well as in the sphenoid sinus. As you can see here, there is a big mass in the nasopharynx centered to the area of the sphenopalatine foramen, which is usually located here. And this is the pterygopalatine fossa, as you remember. And the mass has extended into the pterygopalatine fossa, and if you have the coronal plane, you'll find that the mass has infiltrated the sphenoid sinus as well. A big mass, heterogeneously enhancing, partly in the nose, partly in the nasopharynx, associated with some bone destructive changes. And here is the coronal images, and you can see the tumor involvement of the skull base, almost totally filling the sphenoid sinus and eroding the skull base bones. And if you have an angiogram, and you can see marked tumor blush with hypervascularity of this tumor. This is the lesion, which is partly in the nose, partly in the nasopharynx, with, let us say, the classic extension into the pterygopalatine fossa. Here is also another example of a nasopharyngeal angiofibroma extending into the pterygopalatine fossa, then into the infratemporal fossa, and in the coronal plane, and you can see part of the tumor is located in the sphenoid sinus. This is the MRI showed a significant enhancement of the lesion in this T1 contrast enhanced fat suppressed image. The remaining pod sequences for the same lesion. This is T2 weighted image. The tumor is heterogeneously hyper intense, and this is T1 fat sat with contrast. Then this is T1 without fat sat and also enhanced, and this is the coronal contrast enhanced image. You can appreciate clearly the extension of the tumor into the pterygopalatine fossa as well as the infratemporal fossa, and you can see the invasion or the extension into the sphenoid sinus. Another example of an esophageal fibroma in a male patient, 16 years old, and here you see a mass, and you can easily appreciate the multiple signal void vessels in the vicinity of the tumor denoting hypervascularity. Also, you can see that the mastoid air cells ipsilateral to the tumor are containing secretions, and this is of course because of the involvement of the Eustachian tube, which is obstructed by this big mass, resulting in retained secretions in the middle ear and the mastoid air cells. On angiogram, you see the significant contrast, the significant vascularity and the tumor blush. So, you know that one of the policies for treatment of such tumors is to do a preoperative embolization for the sublying vessels to reduce the tumor vascularity so that the surgeon is able to remove this markedly hypervascular lesion. And nasopharyngeal carcinoma is also one of the lesions that can invade the skull base. And the clinical triad, which is composed of asymptomatic mass due to lymph node enlargement, hearing loss due to otitis media secondary to obstruction of the Eustachian tube, and the bloody nasal discharge. And we have presented so many cases of nasopharyngeal carcinoma in the lecture of imaging of the parapharyngeal space, and we'll see some of the other examples, especially those which have infiltrated the skull base. You remember the staging of the nasopharyngeal carcinoma. T1 is a tumor confined to the nasopharynx. T2, the tumor has extended into the nose or the oropharynx. T3, there is invasion of the bones or the paranasal sinuses. T4, intracranial or intraorbital extension. And nasopharyngeal carcinoma, when it extends superiorly, it will involve the skull base, and many times it can extend intracranially. Then, anteriorly, the tumor will extend into the nose, posterior nares, in the pterygoid fossa, and affects the posterior aspect of the maxillary sinus and also the infratemporal fossa. While posteriorly, it will infiltrate the prevertebral muscles and may erode the adjacent bones. Then laterally, it will involve the parapharyngeal space, encroaching on the parapharyngeal fat, while medially, the tumor can cross the midline to the opposite side. Inferiorly, it will go to the oropharynx. Superiorly, it will infiltrate the skull base with an intracranial extension. This is a male patient, 65 years old, with a tumor infiltrating the right side of the nasopharynx of intermediate signal in the T1 and the T2 and the T1 weighted image with appreciable post-contrast enhancement, as you can see here. Then the coronal images of the same patient showed the extension of the tumor through destruction of the skull base intracranially, involving the right paracellular area as well as the region of the cavernous sinus. Another example of a nasopharyngeal carcinoma infiltrating the left side of the nasopharynx with anterior and posterior and lateral extensions Also, it extends medially across the midline with a superior extension through destruction of the skull base, infiltrating the left cavernous sinus. And this is the tumor in the sagittal image, and you can see the invasion of the sphenoid sinus as well as the posterior ethmoidal air cells with almost total infiltration of the clivus. And this is another example of nasopharyngeal carcinoma in a male patient, 80 years old, and the tumor is located on the right side. It shows intermediate signal in this T1 weighted image, and it is associated with bulky lymph node enlargement, bilateral lymph node enlargement, presenting as a masses deep to the sternomastoid muscle. And this is the lymph node mass, which is considered one of the clinical presentations of nasopharyngeal carcinoma, since the patient may not feel at all the primary tumor, but it may present by bulky lymphadenopathy due to metastatic involvement. And this is an example of nasopharyngeal carcinoma, which is located exactly in the midline. It involves both sides of the nasopharynx, more on the right side, with destruction of the skull base and extension and invasion of the sphenoid sinus. Then we came to the skull-based metastasis. As I have mentioned before, they have non-specific imaging appearance, and they are usually suspected whenever you have the positive clinical history of the presence of a primary malignancy. The treatment of skull-based metastasis is usually by radiotherapy, and some of the metastatic deposits may be surgically removed in certain conditions. In this patient with left breast cancer and left trigeminal pain as well as diplopia, you can see there is a destructive mass involving the apex of the petrous bone, and this was a metastatic deposit. And these are the remaining imaging series of the same case. And here you see there is the destruction of the apex of the petrous bone with involvement of the carotid canal, and also there is encroachment on the sphenoid sinus. There is erosion of the posterior part of the clivus, and you see also this destructive changes near the foramen lacerum and the apex of the petrous bone as well. Then this is a bronchogenic carcinoma involving the left parahilar region. And this carcinoma has been proved to give metastasis to a meningioma already existing in the intracranial. Then this is the initial appearance of the lesion, and you see a homogeneously enhanced lesion based to the greater wing of the sphenoid bone with some internal matrix calcification. The lesion showed some diffusion restriction, which is almost typical of a meningioma with no surrounding edema. But 6 months later, you see there is marked enlargement of the tumor size with development of vasogenic perifocal brain edema, and this was surgically proved to be lung cancer metastatic to a brain meningioma. You know, the skull-based chordomas will be discussed in details in the posterior skull base, and these tumors are rare and they occur commonly in the skull base near the clivus and also in the sacrum, the terminal parts of the spinal cord, and the tumor may present at any age. It represents about 6% of the primary bone tumors, and you know that this tumor is resistant to chemotherapy. The accepted surgery, the accepted therapy is resection with post-operative irradiation. And this tumor is characterized by its destructive nature and is seen, as I have mentioned, in the terminal parts of the spinal cord near the region of the clivus and also near the terminal end of the sacrum. And here you see a big mass centered in the craniocervical junction with erosion of the inferior part of the clivus, encroachment on the spinal canal, and compression of the spinal cord. In T2 weighted image, it shows some increase in signal intensity, and after contrast, it shows heterogeneous post-contrast enhancement. And this is the appearance of the mass in the axial image with heterogeneous post-contrast enhancement. Then this is a classic appearance of, let us say, classic appearance of a chordoma, which is centered to the region of the clivus, invading the sphenoid sinus with some bone fragments, which may represent bone bone fragments from the destroyed bones and also may represent matrix calcification. The tumor will show heterogeneous post-contrast enhancement. Of course, the differential diagnosis of this mass will include sphenoid sinus carcinoma, sphenoid sinus metastases, and lymphoma also is one of the possibilities in this particular area. Then all these can be included in the differential diagnosis. Sometimes, whenever you have MR images, especially the T2 weighted images, and you remember that the chordoma will show very bright signal similar to fluid in the T2 weighted images. This is T1, you see the tumor, and post-contrast T1 weighted image, you see the enhancement. And this is the appearance of the lesion destroying the region of the sphenoid sinus with extension into the prepontine cistern. In the axial T2 weighted images, you see that the tumor is bright. It's not that bright, similar to the CSF, but is somewhat bright, as you can see in all these images. And this is the rest of the exam showing some pattern of contrast enhancement. Then we came to the mangiopericytoma, and you remember that this tumor was classified separately as one of the intracranial tumors, then classified in conjunction with meningioma and in the later classification of WHO for the intracranial neoplasm. This lesion can also occur in the head and the neck. It represents about 1% of the vascular neoplasms. And then the age incidence is in the range of 35 to 45 years of age. It has a tendency to recurrence and also to give distant metastasis. The location of the lesion is almost similar to that of a meningioma, and I remember that I have said that both can be considered as one entity in the recent classification. Then hemangiopericytoma also, if it occurred in the head and the neck, it will not have a specific imaging criteria, except that the tumor is extensively hypervascular. And the lesion has a heterogeneous density with cystic and necrotic areas that are common. Bone destructive changes are seen in about 90% of the cases. And if you have an angiogram, either by CT or by MRI or by conventional angiography, then we see extensive hypervascularity. You see this tumor in the skull base, centered to the skull base. These are images obtained after contrast injection and can appreciate the intense homogeneous enhancement of the tumor with significant extension everywhere in the ethmoids, in the orbit, in the infratemporal fossa, in the paracellular area, in the nasopharynx, and This is another example of the meningoperitocytoma occurring in the posterior fossa. This will be also discussed in the posterior skull base, but here you see a significantly enhancing tumor in these axial post-contrast fat suppressed images. And on angiogram, you may appreciate the extensive hypervascularity of the tumor with neovascularity and the tumor blush as well. And this tumor was diagnosed previously as a meningioma. It is a homogeneously enhanced lesion based to the dura with no evidence of bone destruction, no evidence of surrounding perifocal brain edema. But nowadays, they combine meningioma and the meningoperitocytoma as a single entity. If the tumor looks like this one, and we may say that this is meningoperitocytoma grade 1. And if it shows some bone destructive changes, we may say that this is grade 2 or grade 3. And I have discussed this in full details in the lecture of the new classification of brain tumors uh, presented by WHO in 2016. And here is another tumor which is considered an extremely rare neoplasm, and you cannot, of course, say that this is from the imaging that this is a small cell undifferentiated neuroendocrine carcinoma. All what you can say that this is an infiltrating tumor looking malignant, and the most common malignancy here is the carcinoma, then the squamous cell carcinoma. Then you may say that this is a squamous cell carcinoma, and on biopsy it proves to be this tumor, which is considered one of the extremely rare tumors of the paranasal sinuses and the skull base. This tumor is also hypervascular. And you remember we have three hypervascular lesions up till now, the angiofibroma, which is a benign lesion, and the meningoperitocytoma, which is an aggressive lesion, and this undifferentiated neuroendocrine tumor. This tumor also can present by epistaxis. But of course, the age is not that of an angiofibroma. The aggressive bone destructive changes and the the extent intracranial will help to differentiate this from the benign nasopharyngeal angiofibroma. This mass may show homogeneous signal intensity. It may infiltrate the ethmoidal air cells and the nasal fossa. Also may extend through the cribriform plate of ethmoids. So it can be differentiated from esinizino olfactory neuroblastoma and of course sinus carcinoma and infiltrating meningioma of the anterior skull base. There is usually bone remodeling and erosion of the cribriform plate of ethmoids, and peripheral cystic component are frequent. And you remember this is one of the criteria of olfactory neuroblastoma, which can also be seen here in this neuroendocrine carcinoma. Then you may feel that this tumor has many of the criteria of the olfactory neuroblastoma, and the differential diagnosis of this mass will include this particular tumor. Then the differential diagnosis of a small cell undifferentiated neuroendocrine carcinoma will include neuroblastoma, squamous cell carcinoma, the melanoma, meningioma, metastasis, lymphoma, and this one, which is also a rare tumor affecting the paranasal sinuses, the sinonasal undifferentiated carcinoma. And this is an example of a tumor which is seen in a male patient, 16 years old. And you see the aggressiveness of the tumor with destructive changes, orbital invasion of the cheek, and extension into the nose, across the nasal septum to the opposite side. and this was, of course, a malignant lesion. And finally, lymphoma also affects the paranasal sinuses. It has been discussed with the anterior skull base, and some of the lesions may extend to involve the middle skull base. And you have seen this example before with the lymphoma infiltrating the maxillary sinus, the nasal cavity, and extending into the infratemporal fossa. And this is the remaining part of the lesion with some retained secretions in the maxillary antra. The differential diagnosis also the same lesions are encountered here, and they are almost mentioned in a combination. And whenever you want to differentiate to mention the differential diagnosis of such a lesion, you should include carcinoma, lymphoma, metastasis, melanoma, and C-zone and olfactory neuroblastoma. Thank you very much. Alhamdulillahi Rabbil Alamin.